Hi, I'm Bill Rapisi, Executive Director of Lymphatic Education and Research Network, and I just want to take this opportunity to thank all of you for joining us today for our Symposium series. I also want to take this opportunity to thank all of you who have become members of LE&RN and help support this series so that we can continue bringing this kind of groundbreaking information to you in your homes and offices. I would also suggest for all of you who have not become members of LE&RN, $5 a month, you can become a member of LE&RN and help support this programming and the research that we do. Thanks very much for joining us, and I look forward to having you become a member.
My symposium is entitled Combining Surgical Approaches to Effectively Treat Lymphedema. And there's an important disclaimer as well for you to look at. And we'll go into what we're covering today. The topics that I'll review are fluid versus solid progression of lymphedema swelling. It's the way that we can look at lymphedema swelling and also better determine how to treat lymphedema swelling and lymphedema in general, both with therapy and with surgery. I'll go over how the fluid versus solid progression of the lymphedema affects patient and surgery selection to achieve the best outcomes for our patients. I'll review the types of lymphedema surgery and also how we can combine these surgical approaches to give very nice results. In addition, I'll go over how safe and effective the procedures are. And then afterwards, we'll have time for questions and answers from everyone who are watching today. Now, key points that I'd like to emphasize are number one, lymphedema surgeries can be effective and safe. These are different from old surgeries that have been gone over in years past, but nowadays they are reproducible and they are safe. Again, different types of lymphedema patients require different types of surgery. So, someone who's early in the disease process will be treated in an entirely different way than someone who's later in the disease process. What's important, or what we think is most important, is that the best results are achieved when the surgery is performed by an experienced surgeon as part of a complete treatment system. This includes therapy as well. So it's not just one procedure, it's really being taken care of as part of an entire system. We emphasize that the patients must maintain the relationship with their home lymphedema therapist before and after surgery. That's someone who's going to know you best, and they will be able to take best care of you before and after the procedure for the best outcome. Finally, lymphedema surgery is not a one-off or a magic bullet or a cure-all, and it does have its limitations, and I'll touch on those as well. Now, we would like to give very special thanks to the Lymphatic Education and Research Network for allowing us the opportunity to bring the information to you this morning. Over there, we've had a lot of support from Bill Rapisi and everyone in the office, and we say thank you very much. Here in the office, what we do is very much a team effort. It's not just about me or one surgical technique or some procedure. It's about everyone who works very hard to take care of our patients, and without everyone, including Julie, Amy, Shayla, Yvette, Gretchen, Mariella, Claudia, and everyone else who's part of the team here or in the hospital, thank you very much. Couldn't do it without you, and our patients wouldn't benefit without everyone putting in the hard work that they do. So, surgery for lymphedema as part of a lymphedema treatment system. What we have put together has been the first complete system of lymphedema treatment which combines lymphedema therapy plus VLNT, which is vascularized lymph node transfer, LVA, which is lymphaticovenous anastomoses, and sapple, or suction-assisted protein lipectomy, as part of a complete system to provide the best outcomes. I'll go over what all these different types of procedures are and what they mean and what we can do with them later in the presentation. The VLNT and the LVAs will be addressing fluid components of lymphedema swelling, and the sapple will be addressing the solid component of lymphedema swelling. All of these procedures have shown significant benefits in numerous studies, especially the decreased risk of infections or cellulitis. Cellulitis infections are extremely dangerous for patients with lymphedema, and reducing these is probably the most important outcome that we can achieve. We also will go over the selection of the type of surgery for each particular patient and when one surgery will be most effective for that patient. And I'll also go over how we can combine these procedures in the proper way at the proper time for an even better effect. Now, what kind of benefits do we see from having a combined approach and a complete system to treat patients? One is that the average volume reductions that we get in our patients run between 86 and 111% when we measure it 1 year after surgery. So we see tremendous reductions, and we often see the size of the affected arm or leg get smaller than the opposite unaffected arm or leg. Again, very importantly, we see dramatic reductions in the rate of infections called cellulitis in lymphedema patients. These can be extremely dangerous. Patients often end up for prolonged hospital stays, and patients have died from these infections. So decreasing these provides a massive health benefit. We see significant reductions in the need and the use of compression garments to keep the swelling and the lymphedema down. And we see significant reductions in the amount of lymphedema therapy required. Why? The therapy after surgery tends to become much more effective, so less treatment sessions are needed. And overall, almost universally, patients look and then they feel better. Things are lighter, there's less pressure, there's less maintenance going on, so there's a significant improvement in how the patients do overall. I'll touch on these older procedures to say that I don't perform these older operations, such as the Charles procedure. These are things where big debulking happens, massive excision of tissues happens, and there's a lot of scarring that happens with skin graft or just scars that are placed in arms or legs. These are things that I no longer or have not performed and are not part of the system that we have. Okay, so progression of lymphedema, fluid versus solid. I've broken down the complex lymphedema progression and disease process into something that's much more simple to allow us to discuss it better and also to determine treatment better for our patients. I see these things and we break these things down as fluid predominant lymphedema issues and solid predominant lymphedema issues. So just like this river here, initially there's a buildup of fluid excess when a lymphatic blockage occurs. As this fluid builds up in a patient, at first it's compressible in an early stage disease process. The fluid can be pushed out and it can be treated. However, the longer the fluid stays, the more inflammation happens with the patient, and there's solid that permanently deposits, mostly fat. Just like the sediment in the bottom of a river, once that river brings that sediment, even if that water is taken away later, that sediment is permanent and needs to be dredged out. One way we can think of this is here is a depiction of the volumes in a theoretical arm or leg. Some of the volume is made up of bone, some is made up of muscle and connective tissue, and some is made up of fat or adipose tissue. Now, when lymphedema happens, there is damage to the lymphatic system. The lymphatic system is part of the immune system and involves circulation of lymphatic fluid. Usually in the United States, damage to this happens because of cancer treatment, although congenital lymphedema can happen as well, which means that someone is born with a defective lymphedema and it shows up at some point in their life. For whatever reason, that damage to the lymphatic system will cause a blockage in the drainage of the lymphatic fluid. That causes this fluid to accumulate and causes the arm or leg to increase in size and swell. So that normal volume that's present initially becomes bigger because of that excess fluid. In addition, the fatty tissues start to change and become diseased as well. This is an early stage 1 type of lymphedema. Again, with aggressive therapy and treatment, that fluid can be pushed down and treated and reduced so that at this point an arm or leg can typically go down in size and match the unaffected opposite side. However, over time, an inflammatory response occurs. So that fluid is a bad actor. It causes swelling of all the tissues, especially the fat. These solids are then put down and result in permanent deposition of fat and other tissues that cannot be reduced by therapy anymore. They're also poorly addressed with procedures such as lymph node transfer or lymphaticovenous anastomoses, and I'll cover that later. This is termed stage 2 lymphedema and is typically later in the disease process. Here, the arm or leg that's affected, even after good treatment, does no longer come down to the same size as the opposite arm or leg on the unaffected side. Here's a depiction. This is an autopsy, and this is a slide that was generously given to me by Dr. Håkan Brorsson in Sweden. And we can see here, this is obviously the affected side on the right. There are permanent deposits of fat compared to an unaffected side on the left side here. So these permanent deposits of fat cannot be treated with conservative lymphedema therapy and cannot be removed by lymph node transfer or LVA procedures either. What's also important is that this fat makes treatment of the fluid component that might exist on top of the solid component even more difficult. It acts as a sponge and holds onto that fluid. So therapy becomes more difficult, and procedures such as lymph node transfer and lymphaticovenous anastomoses also become less effective. Now we can see these things in live patients as well. Here's an MRI scan of one of my patients, and this is a cross-section of a thigh on an affected side, which is obviously on the right, and an unaffected side on the left. Here's the bone in the middle of the thigh, here in the center. This tissue here is the muscle around the bone, and that can be seen here on the left side. And then what's around it here is the fatty tissue underneath the skin. On the lymphedema side, this fatty tissue has hypertrophied or gotten much larger, like in the previous slide. And you can see the permanent deposits of fat which are now present in this leg. What's really important here too is that this white stuff here between the fat is actually lymphatic fluid. So even though this leg appears to be solid predominant, there's a fair amount of fluid that still sticks around and is very difficult to treat because of that spongy fatty tissue that hangs onto that fluid. Here's another MRI scan, just lengthwise view. And again, we can see that the fatty tissue is much larger on the affected side than the non-affected side. And this is how it might look in a patient who comes to the office and presents. This is a patient with solid predominant chronic lymphedema. And this leg, even on the best day, never gets down in size to match the unaffected opposite side. We have to be careful to note that yes, we can constrict that leg just like you can push down a dry sponge and make the size smaller, but if you take off those bandages, that leg will come up very quickly, usually within about an hour or more, or around that time, to spring up, but this size never goes down to the opposite side. That's how we know, or that's one way we know that the solids are present. Now, what does this fluid versus solid concept mean as far as lymphedema treatment? they're treated differently. Patients with fluid-predominant lymphedema are best treated with lymphedema therapy first to remove the excess fluid volume. We want to get that arm or leg down in size as much as possible and as closely matching the opposite unaffected side to make the surgery better and more effective. Then we proceed with a VLNT surgery, which is a lymph node transfer, or an LVA procedure, or both. LVA is the lymphovenous bypass, or lymphaticovenous anastomosis, and this reduces the need for compression garments and lymphedema therapy. So again, we're treating the volume with the lymphedema therapy first in all cases, and then here we're reducing the need for the compression garments and the lymphedema therapy afterwards. In contrast, for a solid predominant lymphedema presentation, this is treated with first lymphedema therapy, again, to remove any excess fluid which might still be present. Then we have another step, which is the sapple procedure, which removes those permanently accumulated solids in a very effective way. Then afterwards, we can still proceed with a lymph node transfer, LVA, or both, to reduce the need for long-term compression and lymphedema therapy. Now again, patient and procedure selection are critical. So there's a proverb, and I've used this slide for many years, that if all you have is a hammer, then everything looks like a nail, even if it's not a nail. Meaning that if all you have is one type of procedure or one type of approach, you're going to apply that to everyone, even if it might not be the best fit there. So again, we don't want to do that. We would like to apply the proper procedure and the proper therapy at the right time to get the best outcomes. Okay. The lymphedema therapist is an absolutely critical part of the treatment process. When performed properly, lymphedema therapy, or even complete decongestive therapy called CDT, produces a maximum reduction of the excess fluid that's present. When we reduce this fluid, it can uncover a solid predominant excess as well. So if all the fluid's down and the arm or leg still doesn't get down to the opposite side, that's a good indication that there's still a lot of solid left over that needs to be treated differently. We feel very strongly about the therapist's input. So when we have a consultation, not only do I have a 1-hour surgical consultation with me, but we have an additional 1 hour with the lymphedema therapist. Again, overall, though, we prefer the patients to be seen and treated by their home lymphedema therapist if they're coming from far away, both before and after surgery. Here, it's me on the left. This is Julie Soderberg on the right in the scrubs. Again, I work with her quite a lot. She's the therapist in our hospital here, and she's an absolutely integral part of why our treatment process works, so that we can get excellent results for our very nice patients, one of whom is here. Now, I'll talk about patients with morbid obesity briefly and how therapy relates. Patients who are extremely heavy are not candidates for lymphedema surgery. Why? One, morbid obesity is an independent risk factor for surgical complications. So it is much less safe to operate or perform surgery on patients who are extremely heavy. Second, surgeries for lymphedema don't tend to work who are on patients who are very heavy. Therapy often does. Now, the lymphedema in patients who are morbidly obese often is actually caused by their obesity. So if we institute good therapy and we institute weight loss first, their lymphedema may spontaneously go away, and we might not even have to do any surgery for lymphedema down the road for them. Here's an example, same patient. These photos were sent by an excellent therapist in our area named Joanne Shinazi. This is before therapy, and this is with therapy only. So this patient had a fluid predominant issue, most likely related to his morbid obesity, and therapy alone fixed that. So no surgery was required. So again, patients that are heavy, we would recommend therapy first, and then afterwards, and then initially weight loss. And if that comes down and the lymphedema persists, then we would evaluate them for as part of our lymphedema system. Okay, so the treatment of fluid-predominant lymphedema. Here again is our volume depiction. There's some excess fluid. Again, this is in a patient where the arm or leg can go down and reach the size of the normal unaffected side. First, we use good therapy to get rid of that excess fluid. This brings the volume down and normalizes it, and then we perform VLNT or LVA to decrease or eliminate the need for compression, garments, and lymphedema therapy. I'll go over what VLNT and LVA are. They're both actually microsurgical procedures, and to understand a bit of what microsurgery is, that means we're working on very, very small vessels. This is a slide I had made previously with Dr. Koshima, and it gives us a scale of what we're talking about. This is a normal microsurgery needle with a microsurgery suture. Here's a lymphedema needle with a lymphedema size suture. This is a fine human hair. I know it's fine, it happens to be my hair. And then this is a tip of a standard ballpoint pen. So these are tiny, tiny, tiny. I'll discuss lymph node transfer surgery. Here's myself and an assistant performing the procedure. This is a procedure that was developed initially by Karen Becker in France and also by Minghui Chang in Taiwan. Excellent surgeons. This is over 10 years ago when I was back in my mid-30s as a fellow still. And again, we brought these procedures here together to incorporate them as part of our system. Lymph node transfer involves transfer of lymph nodes from one area of the body to another. There's a little flap which is produced, which includes a small number of peripheral lymph nodes that are not key to draining that area or that we borrow from, plus a little bit of surrounding fat and tissue, plus an artery and a vein for circulation to support that flap after it's moved to the area that it's needed. Donor sites include the lateral groin area, which is down where the leg meets the body, lateral torso, supraclavicular, which is above the collarbone, submental underneath the chin, or even in the abdomen, such as mesenterial menum. Key point here is that the VLNT needs to be performed by an experienced lymphedema surgeon, because all of these donor sites do have issues and can have issues. The rate of issues are extremely low in all cases. But, for example, the groin area, the torso, and also the supraclavicular area have the possibility and have been reported in the literature of having a lymphedema occur at the associated arm or leg area. And again, we've seen someone with supraclavicular lymph node flap with an arm that's had an issue. Again, risk of this extremely low. There are very low numbers reported, but they can happen. Submental area, that has a risk of the facial nerve, which can cause permanent facial paralysis in the lower portion of the face, and the bowel mesenteric omentum also have a risk of adhesions and other intra-abdominal issues in the future. Again, the risk of these are very low in all cases. Here's a patient that we've had. We can combine a lymph node transfer also with, for example, a breast DIEP flap for breast reconstruction. The patient on the left had lymphedema of the right arm that required therapy and compression garment use all the time to be controlled. The hand was particularly hard to take care of. Lymph node transfer occurred. The garment, in this case, was actually, need for the garment was eliminated completely for day-to-day use, which is a fantastic result. And the therapy also is no longer needed. Close-up of the hands here especially showed this patient's issue where she had swelling, which was particularly hard to treat in the hand here, and that goes down, and we can actually see wrinkles, veins, and other things in the hands. With lymph node transfer, having wrinkles appear after the surgery is, well, it's one of the few procedures where actually wrinkles after the surgery are a good thing. Safety and minimizing risk with lymph node transfer. Again, it should be performed by an experienced surgeon who knows the anatomy. We borrow only a small number of peripheral lymph nodes. For me, I feel it's very important to use sentinel reverse lymph node mapping to map the nodes that actually drain the associated arm or legs and avoid them in surgery. So the mapping allows the surgeon, such as myself, to identify and preserve the nodes that are important to drain that arm or leg and avoid them. It does take additional time in surgery, but we know of no reports where patients have had lymphedema in the adjacent arm or the adjacent leg when the reverse mapping was used. Here's an example of mapping. So tracer was injected before surgery in the right leg of this patient. The tracer goes up and collects in the lymph nodes, and those can be seen as these white, bright dots here. Here we've overlaid it on a CT scan so we can better see the anatomy. When we perform the procedure, we want to borrow lymph nodes away from these areas that drain the leg. So, for example, such as the area here in this green circle, we want to avoid this area. There's a special probe that's designed for this purpose that we would use in the operating room that effectively allows us to identify this and preserve those important lymph nodes. Okay, moving on to microsurgery with lymphaticovenous anastomoses. As opposed to lymph node transfers, where we're borrowing some tissue from another area and moving it into the affected area, here we're performing direct connections between the lymphatics and the veins in front of the obstruction. We use small incisions, identify the lymphatic vessels, and connect them directly to the veins to allow for additional outflow of the lymph to bypass the blocked area. Now again, that lymphatic fluid needs to end up in the veins. In a normal patient or a normal area, that lymph fluid will end up ultimately in the veins anyway. These anastomoses or connections are extremely tiny, usually 0.1 to 0.6 millimeters in total diameter. We tend to perform many of these connections to give ourselves the best results possible and the most outflow possible. And again, they address the fluid component of the lymphedema. You can combine them with the VLNT for an even better result. Here, the modern versions of this procedure were actually developed by Dr. Koshima in Japan. Again, this is a photo of him and myself. He's teaching me how to do these back in 2005 when I was a fellow. And again, they're effective in the long term. One thing I do to help me map the lymphatics is inject some indocyanine green dye. This is taken up by the lymphatics, and we can actually see the individual lymph vessels take up the dye here using laser imaging. That allows me to guide the procedure and find the lymphatic vessels better and easier, and to make better connections. This is what it looks like under a high-power microscope. Here I've taken a lymphatic vessel with some blue dye in it, which helps with the identification of the vessel, and I've sutured it into the side of an adjacent small vein. So this whole thing is on the orders of fractions of a millimeter in diameter. So if this one was 0.3 or 0.4 millimeters, that'd be about right. And here we can actually see the blue dye draining from the lymphatic and going out into the vein and allows that lymphatic fluid to bypass and get back into the venous system where it belongs, rather than causing the swelling in the patient. Here's an example of a patient prior to surgery. This is at 1 week, and you can see the multiple small incision sites that I've made. And then here's a long-term result, 55 months. So the volume's gone down a little bit, but again, we've taken care of the volume before with therapy. What you can't see in this picture is that the patient went from 40 hours, or about 40 hours of self-care, lymphatic, manual lymphatic drainage, garment use, etc., down to less than 8 hours per month. She's able to go out on the lake, for example, in shorts all day and not have a massive swelling in her leg, and the garments that she needs to use, she can use less frequently, and they can tend to be less heavy and less aggressive. Now, what happens when we have solid predominant lymphedema? So we don't have just an early stage anymore. How do we treat that solid predominant part? That has to be handled differently. Again, we start with therapy first. That removes any excess fluid which is still left over. Brings that volume down. Afterwards, we use the sapple procedure, suction-assisted protein lipectomy, to remove that excess solid that's present. That normalizes the volume of our arm or leg. Then when things are healed afterwards, we can still go to try and decrease the need for compression garments and lymphedema therapy afterwards using a procedure such as a VLNT or an LVA, which I've just reviewed. Again, this is used to remove the permanent solid deposits that are present in later stage lymphedema. In these patients, the lymphatic drainage system has already sustained tremendous damage. That's what's allowed the fluid to accumulate, and that's what's allowed the solids to accumulate too. Patients who are candidates for this procedure are already using compression garments and have an arm or leg that never goes down to match the size of the opposite unaffected side. We are aspirating the fatty tissues, but it's very different than cosmetic liposuction. The way the procedure is worked up, performed, and the pre- and post-operative therapy are completely different. I went to Sweden to learn how to do this procedure from Dr. Håkan Borsen, who developed it over 20 years ago. And the key thing here is that, and he's an absolutely fabulous individual, he has absolutely great surgical technique, and we thank him always very much for his instruction and his support throughout the years. Not only did I go, but Julie Soderberg, again here on the left, she's my lymphedema therapist, she went to learn the therapy side. The therapy portion of this is very, very critical to making the procedure work properly. Now, comparison to cosmetic liposuction, this is what we might get out when we perform a cosmetic liposuction. The fat is smooth, it's uniform, there's a little bit of liquid on the bottom. This is what comes out when we typically perform a sapple operation. The fat is pathologic, it's changed. This is much, much harder to remove. It tends to be much, much more solid, and it's very different in character than the normal cosmetic liposuction. The procedure has to be handled differently to be able to remove this material effectively. Again, the therapist is absolutely critical with this. The therapist needs to be involved before, right afterwards in the hospital, and in an ongoing way in a very integrated fashion. It's not possible to perform this procedure and send the patient out to a therapist immediately afterwards without this therapy integrated. Again, therapy is quite involved. Here are the bandages used, and here is Julie performing the wrapping. We find that the therapy bandaging performed in the operating room immediately after, for example, sapple in the leg, improves results and decreases swelling significantly. So, one key limitation of the sapple procedure is that you need to have lifelong compression after the procedure. This prevents a reaccumulation of the lymphatic fluid, which then prevents a reaccumulation of the lymphatic solid. Now, patients who are candidates for procedure already require lifelong compression, so the need for compression doesn't change from before and after surgery. However, we found that our compliance with the garments after surgery is extremely high. Basically, all the patients wear this because we have really produced a massive impact and a massive improvement in their arm or leg, and they get better and they keep wearing the garments. Now what we can also do is add the VLNT or LVA afterwards to decrease the need for that garment afterward, especially during the day. Quick note, patients who have congenital lymphedema and secondary lymphedema, meaning that secondary after cancer treatment, are all equally helped with the sapple procedure. A few case studies. Here's a patient with chronic lymphedema after breast cancer treatment of the right arm. Again, solid predominant. She had repeated attacks of cellulitis, which were so common that she required daily antibiotics to prevent them from accumulating. 898 cc's of volume excess. And here she is at 18 months. So we produce lasting results that are consistent with this procedure. And here her affected side is now actually slightly smaller than her unaffected arm. Here's a patient with a congenital lymphedema that's been present for 46 years. She had a previous excision procedure On the inside of her leg here, long scar, without improvement. She had limitation of the movement of her leg, and because of the mass in her leg, was not able to even bend her knee as much as on the opposite side. She had almost 5 liters, or 4,914 cc's of excess volume. To put that in perspective, that's about 2.5 of the large 2-liter Coke bottles that you might find in a convenience store. Here she is at 6 months after surgery. What's important to see here is that now after the procedure, the patient's actually able to bend her leg, exercise. She's had a new outlook on life and exercising and staying in shape, so she starts to lose weight in general, and the unaffected side starts to get better too. So after 21 months, not only is the lymphedema affected side better, but her opposite side is affected or is better as well. Here's another patient who was in her mid-30s. She had lymphedema for over half her life, congenital, massive swelling in the left side. 1 year again after surgery. The affected side, in this case, is smaller than the opposite side. Here's a view from the back. And we really like getting these pictures too. So this is the same patient as in the photos, actually going shopping for jeans for the first time since she's been an early teenager here. She's able to fit these boots for the first time ever. And this is really great to see. So one note on the procedure is that the sapple procedure does not damage lymphatics if it's performed by an effective team. How does that happen? Careful surgical technique. We also perform indocyanine green imaging to map out any lymphatics, and if they're there, we avoid those with our procedure. So we're very careful on how we do that procedure. Most patients have such badly damaged lymphatics that it's very difficult to even see them. Even so, we use the imaging to further protect the lymphatics. Previous studies have shown that lymphoscintigraphy has not changed before and after the procedure. We've actually done investigations with our patients, and we find that the indocyanine green imaging does not change before and after the procedure. The patients have an easier time caring for their arm or leg after the surgery, and there are no reports in the medical literature of patients getting worse after the surgery. Here are 2 of our papers. These are available from our office with our published medical results. Finally, last thing I'd like to review is the combined and staged lymphedema surgeries to treat chronic lymphedema 2. Again, we can combine VLNT and LVA procedures both together to treat patients who have early stage disease. Here's something we can do to combine it with the sapple procedure to not only decrease that solid volume, but to decrease the dependence on the garments and the therapy as well. So case study here, left arm, lymphedema, after breast cancer treatment. Again, solid predominant. Therapy has already been performed, and all that fluid excess that can possibly be removed has been removed. So this is as small as her arm ever gets. She still requires to maintain that size of her arm and keep it from getting even larger, a class 3 compression garment during the day and a foam compression garment at night. So after 1 year, sapple procedure, the arm gets smaller and approaches, or it's about the size of the opposite side. This is pre-op and post-operative report. Again, this is a result we typically see. And again, I can tell she's wearing her compression garment here because she has a tan line. So she's from Southern California, and she's wearing the garment that's required after the sapple procedure. Stage 2, take a lymph node from the groin area, protecting the lymph nodes in the leg. And this is how she does after that second stage surgery. And again, these are lasting long-term results. In this case, her arm is now small, but she does not need the compression garment during the day any longer. And this is just a comparison to how she looked before surgery. I can tell she doesn't need the compression garment also because she no longer has that tan line. And again, we've published this in the medical literature. So finally, Would like to emphasize that the procedures are not a magic bullet. All safe lymphedema practices, such as avoiding cuts and scratches, caution with flying, wearing a compression garment with flying, for example, need to be maintained by all patients even after a successful surgery. And we emphasize that the relationship with the lymphedema therapist at home should be maintained. And if we do this and we take care of patients as part of a complete system, we love getting texts or emails like this. Here's a patient who is from Minnesota, so wearing the rain boots is a big deal, from what I understand up there. And we're thrilled to see these results. So in summary, lymphedema surgeries can be effective and safe, and we feel the best results are achieved when patients are treated as part of a complete treatment system that incorporates both therapy and also surgery. Again, matching the appropriate therapy and surgery with the appropriate patient. Again, the expertise of the lymphedema therapist and the surgeon and the coordination between both are extremely important. And finally, we do also emphasize that patients should maintain or must maintain their relationship with their home lymphedema therapist as well. That's the end. Thank you very much. And if you have further questions, you can look on our website, and also you can always email us with questions or comments anytime. Now, I'll open the floor up to questions, and I know we've received some questions from our viewers already. So a question from Phyllis: how does one know if, or how does a patient know if they're a candidate for a surgical procedure? Every patient's different, and so a thorough evaluation by both a lymphedema surgeon and also a lymphedema therapist is really critical. That's why we spend an hour for a surgical consult, we spend an hour for the therapy consult. We really want to try and find out where along that lymphedema spectrum you fall as a patient. We want to see how much therapy and treatment you've had before, because we'd like to address that fluid and really take care of that with the fluid as much as possible. And if there's solid left over, we'd like to know that too, so we can really assign or treat you with the best therapy. And if the therapy is sufficient, no surgery. And if the surgery does look like it will help, then we can also recommend a surgical procedure afterwards too. The question is, will I need to wear a garment after surgery, and what kind of garment does it need to be? Excellent question. So typically, lymphedema therapy or lymphedema treatment involves compression garment use. If a patient is not as affected, then the garment can be lighter and it doesn't have to be worn as often. As the lymphedema progresses and as you get in the later stages of therapy, that garment becomes a more and more critical part of the treatment process and needs to be worn more often. After surgery, that garment use can be reduced with VLNT or LVA surgeries. After a those are the ones that address the fluid portion. After the sapple procedure, you still do need to wear that garment. Usually it's a custom fit compression garment. Now the patients, again, who need to be wearing the garment after surgery are the same patients that need to be wearing the garment before surgery already. The lymph node transfer and the lymphaticovenous bypass or lymphaticovenous anastomosis procedures can, and we often see reductions and sometimes even elimination of the need for that garment. So the question is, for stage procedures, why do we do a sapple procedure first and a VLNT or LVA procedure afterwards and not the other way around? Excellent question. The sapple, well, going back to a fluid and solid idea of how we look at lymphedema, that solid material, if it deposits and if the patient's arm or leg has gotten to the point that that solid's deposited, that solid is permanent and it acts like a sponge to make the therapy more difficult and make the procedures less effective. So we want to get rid of that solid first and normalize the size of that arm or leg. Once that's out and it does not hinder or interfere with the other therapy and the lymph node transfer or the LVAs, then we go ahead and do that afterwards. So the question is, can lymphedema be successfully treated even if the patient has had it for over 40 years? And the answer is absolutely. The one patient that I had shown with the congenitally large legs, she had it for 46 years. So the amount of time that's passed is really less important. It's really, where does the patient lie in that fluid versus solid predominant process? Now, if patients had a lymphedema for 40 years, chances are they'll probably have a fair amount of solids that have deposited also, but not always. And so that's something that we really need to sort out carefully with a careful consultation with your surgeon and also the lymphedema therapist. So the question is, if someone has an inguinal hernia, should that be addressed before or after a lymphedema surgery? Preferably, if there are other medical problems that are going on with the patients, we'd typically like to have those addressed first. However, each patient is going to vary, so we want to have that patient have a consultation with the lymphedema surgeon first to make a specific recommendation. But in general, we'd like to have that hernia addressed first, healing happen then, because sometimes we work in an area that can be rather close to that area where they'll be repairing that inguinal hernia with our lymphedema procedures, and we don't want the hernia repair to disrupt what we've done as a lymphatic operation. I see no further questions, so with that we'll finish our presentation. Again, I thank Lymphatic Research and Education Network for the opportunity to present today. Please contact us in our office anytime if you have any further questions. Thank you.